These are some good ones. All right, so read through this one. I have an 80-year-old geriatric patient, type 2 diabetes, admitted to the emergency department, worsening confusion. All right, so they're just coming in. Type 2 diabetics, they're confused. Remember, our geriatric patients, they're always confused. Anything's happening, they get confused. Decreased level of consciousness. So decreased LOC. Which of these findings is most important? All right, and it's so important, we got to report it to the healthcare provider. All right, so with reporting, we know we're looking for something abnormal. So eliminate anything normal if you find those, because you want to focus on your process of elimination. So normal things we're going to eliminate. I start out there. And then if I'm left with everything else abnormal, now I have to prioritize, right? Because we got to find what's most important. So to prioritize, we're going to start out with airway, breathing, circulation. Okay, we got some A's, got some A and B are normal, good. So now we got to prioritize and figure out which, is there anything airway, usually not an airway problem with, in this case, unless they're doing like Kuhlman's, but that would be usually type 1 diabetics who have DKA. Type 2 usually go into HHS, and they usually don't have the acidosis, so they're not usually experiencing that breathing problem, the Kuhlman's to help blow off CO2. So we're looking for ABC. So usually circulation could be an issue for this patient. If I can't find anything in ABC, I start thinking of, well, what else within Maslow's hierarchy of needs? What other physiological needs? And then move up the pyramid. And if we're reporting something, we're probably not going to be doing assessment and all those kind of things. But where ADPI can help you with priority, if you're really looking at something to report, is what's your intervention? What do we need to do about it? So if I'm going to, tell the doctor this is happening, I'm already expecting that he's going to be ordering something or telling me something to do. All right, so what will I do about it? All right. At these two, looks like most everyone is kind of on A or B. A would be an expected finding. Yeah, I like that. So A is more of an expected finding. If I'm between A and B, it's expected. And although it's high, he is type 2, that won't kill him first. And if we're thinking he is having an issue, some other issue related to this confusion and decreased level of consciousness, once it becomes much higher than that, that's when they really get into problems. So he may be at the cusp of something, but not as bad as we would think. And a lot of type 2 diabetics, 80 years old, they probably have been diabetic for a while, right? They're geriatric, and a lot of times they're used to higher blood sugars. So it is expected. That's a good idea, good thought, good clinical reasoning on that. When you look at option B, what does that mean to have an osmolarity of 355? Is that high, low, and what does that mean? And it's in the serum, so they're checking their blood. Their blood osmolarity is 355. All right, good. So that means it's high. Very good. And if I see it over 300, I'm usually speculating it's pretty high. I've seen so many variations on this. So some things are kind of like common. It doesn't change, but some books will say 370s, 380s, 390s, and I see it go up to 300 to about 310, but maybe no more than that. But usually if I'm seeing it over 300, it's high. Yeah, dehydration, very good. If it's high, then their blood is thick, it's concentrated, and that means they have very little volume. All right, so dehydration. So if it's high, that means their blood is thick. So this is where I get the gravy comparison. Instead of saying Kool-Aid, how much water is in the Kool-Aid, you think of gravy. If the gravy's too thick, you're going to add more water, right, to thin it out. So their blood is like thick molasses. It's got the sugar, and if you don't thin it out, it's very thick and it's going to be very concentrated. So blood is thick. That means they're dehydrated, and that would tell me that they need fluid. If they're dehydrated, they need fluid. All right, so that does give me an ABC priority. This is circulation. Okay, that's circulation. If you're dehydrated and you're not having enough fluid volume, your cardiac output is going to be low, your blood pressure is going to be low. Volume equals pressure. So when volume is down, pressures are low, and the body doesn't do good with low pressures, right? Remember the kidneys, they're divas and they don't like low pressure. All right, so urine output greater than 100. What do we think about that? Urine output greater than 100. They didn't tell me how much more greater, it just says greater. So if it's at least 100 and something, is that bad, normal? I think we kind of concluded that A and B were the two abnormal. This was like a maybe. I don't know how much more over 100 they're saying, so we can't read into it. It's greater than 100. Not a bad choice. If you're making good urine, I would suspect that that's great, unless you're doing, um, way much more than that. And we're thinking diabetes insipidus. But this patient doesn't have that indication. They don't tell us he's had a brain injury, brain surgery. Other than if his sugar's high, he's going to have what? Polyuria. And so if you're thinking polyuria, then that is expected. His blood sugar is high. 3 P's: polyuria, polydipsia, polyphagia. All right, so expected. This was expected. And our blood gas is normal, 7.36. And if he's type 2, if we're worried about DKA is the worst thing that can happen for them, not DKA, but HHNS, they don't go into acidosis for type 2, right? They're usually in HHNS or HHS. And this was normal, so I would get rid of that. All right, so A and C expected. B is not expected. And like you said, it's someone mentioned it's B is high, can cause fluid imbalance, and it's high in its dehydration. Very good. That was our answer. So just without clinical reasoning, our first thought might be pick the glucose. The glucose is high because we're so focused on the diabetes, but prioritization leads you to what will kill him first. It's the dehydration, right? Compared to a 380 blood sugar. All right. This is just a slide comparing the two, HHNS and DKA. And treatment is going to be similar to DKA, but the number one thing that they usually need is fluid replacement. They may need some electrolyte replacement, sometimes insulin administration, but usually not as strict insulin administration as DKA needs. Fluid replacement in the older client must be done very carefully, right? Because we don't want to set them into heart failure. So we got to watch that. And then this was a good chart in Saunders comparing the two. And here was the osmolarity for our HHS, greater than 350. Can vary for DKA, but it's usually going to be pretty high for HHS. They're mostly dehydrated more than anything. All right, so be able to differentiate between the two. Older clients, a lot of times they're on diuretics. They have an impaired thirst mechanism. They don't have that same mechanism to drink more fluid like our younger clients. So they get dehydrated easily, and they have inadequate fluid intake that can lead them, those type 2 diabetics that are elderly, can lead them into HHS. Their blood sugar usually gets greater than 600, right? When it's really bad for them, when they get into HHS. So blood osmolality is high, polyuria, normal blood pH. Those are all some of the characteristics. Our first priority for this client is going to be fluid replacement to correct the dehydration. All right, last question. If we have time, might go over a little bit. Usually I'm under, but we'll go over. We're making up for time. Last time we got out kind of early. Last question. This one's good. This is our pituitary question. All right, we have a patient who is 30 years old. She's a female. So a lot of times when they're giving you the age and they're giving you gender, pay attention to those. They had a hypophyseectomy. She had a pituitary tumor. And now the patient's asking, how will the removal of the pituitary gland affect her? Which is the best response? All right, so clinical reason through those. What do you think is the answer? All right, any thoughts on the answer? So we're having to focus in on what was removed, pituitary gland. That's where I would start. All right, we got some C's. Good, very good. Awesome, awesome. So if we're focusing on that pituitary gland, we know what hormones that pituitary gland secretes. And so that's where your focus wants to be. Um, Now, a lot of people would look at this and say, okay, she had some brain surgery. She's at increased risk of ICP and she can have seizures, right? And so that would take you to this. So if you got down to those two and we got rid of blood sugar, because pituitary gland doesn't really affect your blood sugar levels and put you on insulin, doesn't really affect your immunity. So if you get down to C and D, focus in on your subject. Pituitary gland was removed. Because of the surgery, you will be at an increased risk for seizures. This is a possibility, right? This is one of those things that's maybe, but we're going to be monitoring her. The doctor will decide if she needs to be on any type of medication. We do know there is a risk for ICP after any type of brain surgery, and that could lead to a risk for seizures. But it doesn't, if we go back to what our question asks, she's asking about how the removal of the pituitary gland will affect her. So that one more so focuses on the surgery itself, which could be any kind of brain surgery. It's not specific to pituitary, right? So any maybes we get rid of, because this could be anything. It's what I usually say for most brain injury patients, brain trauma, brain surgery, craniotomies. For any of them, yes, they will be at risk for a seizure or for ICP. We're going to be monitoring those things. But specific to the pituitary gland is going to be C, right? So if you're down to those two, you want to focus in on who your patient is. She's 30 and she's a female. Thinking about pregnancy, she might have a harder time getting pregnant. So if you remember your pituitary, a client of mine, we're doing this endocrine study, and she's like, oh my gosh, we got all these glands, all these hormones to know. And so here's our FSH and LH. Those hormones stimulate the follicle in the ovary and regulate our menstruation and all those things. So that will play a part in her ability to get pregnant. So without that, that's the anterior pituitary, she can lose that ability. It will be harder. She may have to do like a fertility clinic or something if she wanted to have a baby. So common treatment for pituitary tumors, get rid of that pituitary gland. It's called a hypophyseectomy. Because the pituitary is related to or responsible for the LH and FSH hormones, for excreting those, then that would be the number one complication, more specific to that surgery, is infertility, problems with fertility. All right, Cessation of menses, because remember it controls our menstruation, so she may not have a menses, and if she's childbearing, she was 30. Removal of the pituitary gland doesn't have anything to do with glucose or immune system. It doesn't. The gland itself doesn't. Removing the gland itself doesn't cause seizures. The surgery can put them at risk, but not the gland. All right, we only ran over a little bit. Any questions? Anyone have any thoughts, comments, suggestions? Glad you all could make it tonight.